Evening. My name is Dr. Yashika Dooley, and thank you all for being here for Menopause 201. I am a board certified urogynecologist, and today we have Dr. Mary Beth Lewis Boardman, and I'm going to let her introduce herself, but she is also one of our menopausally trained physicians, and we are going to be talking all about menopause and how the metabolic syndrome affects women that are both perimenopausal and postmenopausal. I am also one of the medical directors. I have been with Genève for a couple of years now, and I'm also a urogynecologist. So I love talking about these topics. We would love for you all to engage in the chat, put lots of questions there, because as we talk, we will be going to the chat and also pulling questions from there and hopefully having a very lively discussion this evening. I'm going to now turn it over to Dr. Boardman. Would you like to introduce yourself and give us some information, whatever you would like everybody to know this evening?
Absolutely. So I'm Mary Beth Lewis Boardman, have the longest name that it seems to exist, at least within my area in medicine. But I'm a board certified OBGYN and also a Menopause Society certified physician. Have a really keen interest in menopausal healthcare, actually, since I went into private practice in 2002, because I went into private practice the month after the Women's Health Initiative study kind of came crashing down and changed our world with respect to menopausal hormone therapy. I have a very big personal interest as well in weight management and obesity medicine. And that's been something that's been throughout my practice over the years, and has been more of a concentration of mine since 2021 when I stopped doing deliveries. So really excited to be here and hoping that we can together really help to share some of the knowledge and things that we have experienced with our patients and grown through over the years in our practices.
Cool. Well, thank you so much. I appreciate you being here to share your expertise and knowledge. So let's just start off. Tell me when you are seeing patients in your clinic. I know a lot of them, especially now that it's January, are coming and asking us about things that are just changing. You know, they're talking about they are putting on weight. Oftentimes they're talking about that menopausal belly or the belly fat, but they're also maybe worried about having elevated cholesterol, or maybe they have hypertension. When you are seeing all of that and knowing that tonight's topic is about talking about metabolic syndrome, tell me what you were thinking and how you really start to talk to your patients and the things that you are thinking about and want to make sure that they know.
So I think you hit the nail on the head. The first thing that patients tend to really come in and complain of or talk about is oh my gosh, I've never had a problem with my waistline and I don't really have a waist anymore. I have this belly fat. I don't know where it came from. I exercise every day. And I find it very interesting because I think before, like as women, before we ended up experiencing, well, for me, because I'm 52, experiencing some of the changes that my patients have had. But in my earlier years of practice, you know, I'm seeing somebody who's in her late 40s, early 50s complaining about this belly fat. And I'm thinking, well, stop eating so much and work out. And
Yeah.
what has been amazing to me is seeing that, you know, I live in an area where I see a lot of patients who are professional triathletes. They're professional athletes in various capacities, whether they're marathon runners or swimmers, what have you. And I'm in Central Florida, so it's pretty nice most of the year. So they're working
Mm-hmm.
out all the time. And even my patients who have been completely regimented with their diet, they are running 10 miles a week, they're adding some weight training in, even they will come in and say, I don't understand why I've gained this 10 pounds and it's all around my waist. And when I started noticing that, you know, again, because these are women in my community that I've gotten to know, I know that they're not just sitting on the couch and getting lazier. You know, it seems like this is something that affects everyone. And secondarily, it's when they start to mention the weight gain that is really bothering them, they feel bad about themselves, they don't like it, they feel like they can't lose the weight. They don't usually come in and mention what their PCP has found
Yeah.
until I actually ask, have you had any changes in your labs? Has your primary care doctor noticed that your cholesterol is increased? Has he or she noticed that maybe you're pre-diabetic or your fasting glucose has become a little bit more elevated, and that then goes into other things. You're focusing on the belly fat, but are there
Yeah.
other underlying things going on that that's contributing to the development of the belly fat in this perimenopause to menopause transition? So going into things like, well, how are you sleeping? It's
Yeah.
amazing to me how many people don't realize the connection between poor sleep habits and decreased sleep efficiency and decreased amount of sleep and the development of added weight and excess weight. So it really becomes a very long conversation,
Hmm.
because it is something that really represents a lot of, it's a multifactorial thing. It's not just one thing that's happening, at that time. Yet it is something that is so incredibly distressing to almost every patient, regardless of what her background is and what her initial BMI is, and whether or not she's struggled with weight in the past or not.
That is so true. And it's interesting because you do talk about the women who are avid exercisers. It's not like they're sitting around, it's not like they are not doing things, or it's not like they haven't been very active. And I find that sometimes they are the most frustrated because they're like, I'm already
Absolutely.
doing all the things. What else can I do? I
I
don't have
can't do
time to
anything
train
else. There's
anymore.
nothing more for me to do,
Yeah.
and when they bring that up, my next conversation again, because usually these are women that are in their late 40s, early 50s, mid 50s, I'll talk about, well, let's think back to when you were in your 20s. When you were in your 20s, were you following the same, strict, dietary patterns, lifestyle activity patterns that you do now? Or did you find that as you went from your teens to your 20s, you had to adjust what you were doing to help to kind of keep at a certain level of fitness or a certain weight? And I talk about the fact that, or kind of bring up and let them kind of think about whether or not what worked in their 20s, did it work in their 30s? Did what
Yeah.
they did in their 30s to help maintain their weight and their health optimization work in their 40s? And the answer is usually no. They realize that, every so often they had to change things up because they were dedicated to trying to be healthy and facilitating, again, just a healthy lifestyle. And the hard part is it's so ingrained in us that if we're doing everything to be healthy, we're going to look a certain way as well. And I think that we not only start facing the changes in our hormones and how we physically feel, but then we're also changing, we're dealing with that aging aspect of this whole process. So, we're decreasing our lean mass, and our fat mass increases, our visceral fat mass increases, and those are happening
Yeah.
regardless because of the typical aging process.
Yeah. So, how do you tend to counsel your patients? Because a lot of times, like you said, they're coming because of weight or they're coming because of the belly fat, and now you are talking to them usually about starting kind of hormone replacement therapy. How do you talk to them about the effect specifically of the hormone replacement therapy on metabolic syndrome? What could they expect, or what are we also looking for?
A lot of it depends on where we're starting point is. Look at dyslipidemia, what are the specific factors that this patient in front of me may have going on? And then secondarily, what are her symptoms? Is it just
Yeah.
weight gain? Or is it, I'm gaining weight, but oh yes, in addition, I have, vaginal dryness, discomfort with, sexual relations. I'm having hot flashes and night sweats. I can't sleep at night. My mind is racing. I'm having palpitations. There's such a whole slew
Yeah.
of symptoms and symptomatology, but the fact is they're all usually related on some level. And I
Mm.
usually will have a patient kind of go down the list of what she's experiencing. I know the weight gain is distressing. Let's look at other factors that may be contributing it, to that. And then as she goes down the list of, oh, this is what's bothering me, then it's a matter of bringing in her medical history. When was the last time you had labs done with your primary care? Are you up to date? What medications are you on? What is her blood pressure on that, that particular day? Is she a smoker? Is
Yeah.
she not a smoker? What is her, past medical history with respect to, have you ever had a DVT, a pulmonary embolism, any thromboembolic event? Have you ever had breast cancer, pre-breast cancer, family history of breast cancer, any genetic markers? Going through all of that, and then
Hmm.
getting down to, is this somebody who is a candidate for hormone therapy? How is that going to potentially benefit her? And if she's not a candidate for hormone therapy, how do we then kind of go down that list of her symptoms with respect to priority of treatment to try and address them in the best way possible? Once we have somebody who's sleeping well, if somebody has an elevated BMI, they're not sleeping well, or they think they're sleeping well, but they have obstructive sleep apnea. Has that been addressed? All of those factors together. So much to start with. And it really does depend individually on the patient's symptomatology, but also her medical history.
So when you are talking to the patient, so say you do have a patient that is a candidate, there are no contraindications why they can't start on estrogen, the patch and progesterone or whatever. And they are asking, I also happen to have, or, my doctor maybe told me that I am pre-diabetic. So do you ever kind of address how that starting of the estrogen and progesterone might be impacting their pre-diabetes numbers and what they might be looking for or what they might want to do differently?
Oh, absolutely. So I think the interesting part when we think about belly fat, of course, she's coming in worried about her belly fat, but in the end, that's making her insulin resistance likely worse because of that central obesity. We know that with the initiation of hormone therapy, estrogen and progesterone combination, oftentimes we can see sort of I will explain to patients, it's almost like having a cut that's bleeding and, it might need stitches, but you put your hand on it and you stop the bleeding, and that's kind of what estrogen therapy will do for this particular aspect of menopause. If somebody is pre-diabetic and they're a candidate for hormone therapy, we may be delaying their development to type 2 diabetes somewhat with that addition of estrogen into her life. Obviously, then it's a matter of looking at lifestyle as well. And I think that's the big thing. Everybody wants that easy, just give me hormones so that I can lose the weight. And when I have follow-ups with patients who are really concerned about weight gain and hormone therapy, to them, they look at it like this is the end all be all. I just need to take that progesterone at night and slap that patch on, and I'm going to be just like I was, within a couple of months. And they'll come back for that follow-up and need to be reminded that, similar to having any other condition that can increase weight gain. So a lot of women have thyroid dysfunction. Do you remember when you were diagnosed with thyroid dysfunction? Maybe you gained a little bit of weight, you were really tired, you got started on your medication, your levels were normal, you felt less tired, but your weight was the same. It may help to level things off, but if you're going to lose the weight, you have to do that with that healthy lifestyle, increasing activity, which is so incredibly important at this part in our lives, since we tend to become more sedentary anyway. Getting resistance training in there to start building back some lean mass that we've lost, and all of that can have the positive benefits, obviously, on our glucose metabolism, but also on our lipid metabolism.
Yeah. So when you are talking to your patients and they have signs of metabolic syndrome and they are candidates for hormone replacement therapy, are you ever thinking about titrating, so to speak, their medications? Like, I've had patients come in and they start on, whatever dose of the estrogen and progesterone, and they kind of have this idea, if a little is good, more is better, and they just want me to keep ramping it up regardless of if they have any lingering hot flashes or night sweats. They're just thinking, well, I really want to get maximum benefit, and they think maximum benefit is like, let's get as high on the dose as possible. Do you have any thoughts about that? Do you know of any data, or how do you treat those patients, and how do you counsel them when they're having those discussions with you?
I mean, the biggest thing, I kind of liken this to somebody who comes in to see me for the first time and she's on something like pellet therapy, which I don't prescribe, and it's not evidence-based. And, they're like, oh, but look at my levels, and, I need my estrogen level higher. It's always my favorite thing. The fact is there's such a range of what is normal and the most important thing to know is that, are you having symptoms or are you not? And the interesting part to me is when I've had somebody who starts chasing the numbers and then they start saying, well, I felt a lot better, but now I feel worse, so I need even more. Yeah. And that's the conversation of, well, too much of a good thing is not a good thing. Having a treat that tastes really good is great, but if you have too much of it, your stomach hurts and then you get sick. It's kind of the same thing. So are we doing levels? No, we're not doing levels. Are we titrating to symptomatology? Absolutely. I usually will start a patient, obviously, when we look at estradiol transdermal patches, we've got 5 different doses to start with, and the typical thing is to start with that middle of the range dose of 0.05, estradiol patch with 100 milligrams of progesterone if they have a uterus. If they don't have a uterus, then we don't necessarily need that uterine protection. Sometimes I will start progesterone for other reasons, kind of a little bit off label. We know not necessarily indicated if somebody does not have a uterus. But the fact is, starting at that place and having them come back, then it's a matter of going through symptomatology and really talking about, we are treating a patient, we're not treating numbers. Treating your symptoms is the most important thing. So if I like to start in that middle range, and if they're still symptomatic and they're doing well otherwise, going up to that next level and only titrating to when they actually are feeling like they're getting their quality of life back.
That makes a lot of sense. And I
Do
think
you
sometimes
know,
that's,
have you
go
seen
ahead.
any like recent studies related to, over treatment, I guess, or really elevated levels of estrogen? And I asked because
I
you had
have
mentioned it, but I haven't seen anything recently.
No, I haven't. It's one of the things that I've been looking at more recently, mainly because we are doing our weight management program. And I do have lots of people that have those pre-diabetic numbers, and patients will come to me and say, oh, my hot flashes and my night sweats are better, but I still have, the belly fat's not going away. And I would really like to be able to come off of my blood pressure medication. There are other things like now that they've been educated. And so now they are wanting to go up on their medication, or they're thinking, well, like the long term protective effects, like I just want to keep going. And how can I maximize that? So it's something that I've been looking into. I haven't found any data. And I do kind of let them know that, the same thing as you, like just because a little is good, more is not better. But I do always just try to have the conversation with them. And I really try to get them to speak to me as to why they are looking for a higher dose of medication. Are they still having night sweats or hot flashes? Are they
Right.
still having problems sleeping? Because sometimes it can be a little vague. And I think also some people are like, well, I think I have a little bit of brain fog. I think I have a little bit of whatever it is. And it's really trying to reel them in and making sure that we are pairing as a team, but making the best diagnosis. And because
Yep.
there's not a lot of data specifically to that, it's like,
Right.
okay, let's try to figure out the best way to do this to get you the best benefit, but not having unrealistic expectations is kind of what I'm talking to them about. Because I think a lot of them are thinking, oh, I start the medication, everything is going to go away. And like you said, that's not how this works. I
Right.
usually tell them this is just one part of it, and it's a layering effect, right? We've got to work on
Yes.
all of the things that are going on, because it's not just the lack of estrogen that has caused you to have metabolic syndrome. It's a part of it, but
It's
also now we need to look at what else you are or are not doing.
Yeah, I feel like in a lot of ways the lack of estrogen or the lower estrogen part of it is kind of the straw that breaks the camel's back for them with respect to metabolic syndrome. It's the
Yeah.
thing that gets them in to say, you know what, I need to do something about it. And I think it opens up the door to, number one, support with their primary care doctor. I mean, it's I get that classic patient comes in and she's like, oh, well, this is going on, and my primary care doctor told me I just need to lose weight. And we know there's more of a conversation than that.
Yeah.
But when they have these other symptoms that are really negatively affecting their quality of life, it opens the door to be able to address why their primary care is focusing on that weight loss and how that's going to actually impact them positively with respect to their menopause and their menopausal symptoms.
Yeah. And being that you are obesity medicine trained, tell me if you have any idea as far as when people are coming in, that they are overweight. Oftentimes we kind of know their height and their weight, and we kind of have a BMI already, and they are candidates for hormone replacement therapy. How do you kind of navigate that conversation and talking to them about maybe the benefits of trying something like metformin, which I think, has lots of different impacts and effects, and
Mhm.
maybe starting a conversation about why looking at doing something more than just the HRT, or how that's going to affect and what they should be looking to do.
A lot. Well, that's a whole other very long appointment in terms of,
I know.
what's driving their eating habits, because we know that
Yeah.
weight disorders are much more complex than just how much we eat and willpower and, how much we burn.
Yeah.
And so trying to think of the best way um to approach that answer. So when I have a patient who comes in and we're opening that door, um, it's really a matter of connecting with them, first and foremost, and really, man, I'm trying to think of the way. This is what I get for working all day and getting really tired.
Well, let me break it down. I guess one of the things that a lot of my patients come in and say is that their doctor maybe has told them they are not diabetic. And so really they just need to do lifestyle modifications. They just really
Yeah,
need to start losing the weight. And in my mind, I'm kind of thinking, yes, that's one part of it. But also, I am thinking kind of longer term and saying, okay, what are the things that we can start thinking about or at least having a discussion about now? Because I know that it's going to impact these other things later on, and that just going on hormone replacement therapy for most women is not going to be the end all be all.
no, it's not the long-term fix for their metabolic issues. All right. I mean, especially if those metabolic issues are related to obesity, dyslipidemia, hypertension, and
Right.
increased risk of cardiovascular disease. So, I mean, going back to metformin, I knew I'm like, you mentioned something. Why am I blanking on it? I think one of the nice things about being an OBGYN is that we've had so much experience over, like for me, a lot of experience over the last 20 plus years working with patients with polycystic ovarian syndrome and insulin resistance and the use of metformin in those patients. And it makes it very easy to then go over history, talk about, have you been on metformin before? Have you had gestational diabetes? What is your family history of diabetes? And then looking at long-term prevention. When you have some of these patients who are also then developing elevated LFTs and we're looking at, their liver being affected by this pre-diabetic state and all of that, getting them on something that can help them metabolically can be incredibly helpful in terms of, when they start seeing, oh my gosh, I've lost 5 pounds in this past 2 months. The amazing thing is how it wakes them up to feel good about themselves and see that they can actually achieve, that weight loss, that the weight loss that to them represents success, represents positivity, all of that, and knowing that they're working towards, being healthier, decreasing their risk of type 2 diabetes, that sort of thing. But I do go through a lot of, when you have somebody with insulin resistance, going in that metformin direction can be really helpful. What do we do with somebody, somebody comes in and says, well, I really try, but, once I start eating, I can't stop. You look at a binge eating disorder, there's so many different factors, and there are so many different pathways that you can take in terms of medication and support, whether it's, a mental health therapist, for somebody who's really struggling with nighttime eating, really giving them, patients the ability to have certain parameters that are going to help support them not being hungry all day. So many women have such a deficient diet when it comes to protein, for example, and protein we know as a macro is going to be one that helps to create more satiation during the day. There are a lot of women who in their 40s did really well with intermittent fasting, and then they hit that wall in their perimenopause trend, to menopause transition, and they're like, it's not working anymore, and now I'm gaining and I'm hungry all the time. So then it's breaking it back down and going, okay, what worked then isn't working now. Your body is changing. How can you accept those changes but also work with them, in a way that allows you to be the healthiest that you can be without getting focused on a certain size or a certain number on a scale.
Yeah, no, I think that's definitely true. And one of the things that I have found is bringing in those numbers and really talking about it can be very helpful to get them on board with really focusing more on lifestyle changes.
Absolutely.
Oftentimes they're kind of like, yeah, they said I'm pre-diabetic, but the doctor said it's fine. I don't need medication. And so, because of however it was presented or however they heard it, it might have been presented differently, but however they heard it, it's almost like they kind of discount the numbers. Like, oh, yeah, my cholesterol's a little high. They said we're going to follow it and like, we'll check it again in 6 months or check it again in a year. And because of the way that they heard it, they don't put as much, I guess,
Emphasis.
emphasis or on
Mhm.
it. And so, how do you approach those patients? Because it's trying to get them on board mentally to be like, well, it's great that you're not diabetic. Now's the time for us to like go all in and try to do something, is kind of how I attack it. But I'm
Yeah.
always like curious, like, how would you try to do it? What are you thinking? Like both now, but also maybe talking to them for long-term health reasons.
Absolutely. So I usually will approach things like that with the whole knowledge is power. I feel lucky in that my current practice is not being taken up by me spending 10 minutes doing an annual exam and a pap smear and a breast exam along with counseling. I can sit for a good 30 minutes and look at something specific within their labs, within their numbers. If they don't have recent labs, and they don't have a PCP, I'll order their full set of labs to go through. Let's
Mhm.
look at your fasting glucose. What was the trend? All of that. And when you share with them what the trend of the numbers can mean, you're not in this position where you're at risk of having a heart attack tomorrow, or whatever. You're not at a super high risk, but this trend shows that if you continue the way you're going, these are the things that we need to look at and be
Yeah.
concerned about. Sometimes plugging numbers into their ASCVD risk profile can be helpful. When they come to me and they're, I like to partner. I like to think that when I'm educating them, I'm also partnering with their PCP without their PCP even being
Yeah.
there. Because then, when they have two physicians that are mentioning the numbers and giving as much information as possible and relating it back to what they're coming in concerned about with me, gives them more. I think it's motivating to see potentially what they can prevent by doing some simple things. I do like to approach my patients with, when we talk about, the type of exercise and activity level, 150 minutes of moderately intense exercise per week at minimum. If you're looking at weight maintenance, if you're looking at being healthy in the menopause, that's that minimum plus 75%, or sorry, 75 minutes a week of higher intensity, vigorous intensity exercise, plus 20 minutes a couple of times a week of resistance training. You can't put that on somebody all at once, especially
Yeah.
if they're in the position of, I don't know what to do. I've never had to do anything. And now this is
Mhm.
changing and I don't feel good. Then it's going into the, well, do we need to, think about, what do you think you can accomplish today? It's not about what I think they should do. It's
Yeah.
about what they can fit into their lifestyle, and having an understanding that what their home life may be in terms of what their tasks that they need to do every day is this person is at home and taking care of an elderly parent who needs them all the time. So what can they do within their home? And opening the door up to exercising and doing that activity doesn't mean that you're putting on gym clothes and going to a gym and having a gym membership. It can be
Yeah.
something as simple as, okay, my elderly mom is taking her nap for the day. She's fine. I have a set of stairs in my house. I'm going to walk up and down the stairs 3 times today.
Mhm.
So I've had patients that I've started with the, how, you're wearing a smartwatch. How many steps per day are you taking? Oh, yesterday I did 750. Well, if somebody's only doing 750 steps a day, and they don't have any mobility issues, regardless, to say you need to do 5,000 steps a day to start would be
Yeah.
incredibly overwhelming. So I really like to partner with them and ask them, what do you think you could do? Do you think that, walking 250 more steps a day and getting to 1,000 this week or next week or this month is something that you can do? And just continuing with that partnership, and honestly having frequent enough follow-ups to make sure that they have their questions answered, that they do have an understanding of what their own labs, what their numbers mean, what a BMI is. I mean, because all of these things are things that we throw around in appointments, but to them they're just numbers unless you relate it to them somehow, and unless you really give them the tools or the resources to make a difference in their lives.
Yeah, no, that totally makes sense. And when you are talking to your patients, like in the beginning, you started talking about those women who are already really physically fit, they've already been running or exercising or doing whatever, and now all of a sudden they are having that diagnosis of metabolic syndrome, or all of a sudden they're getting the belly fat, but now they're being told, that they are having elevated numbers, whether that be pre-diabetic or maybe their blood pressure numbers are going up. How do you talk to them? Because they really do feel like, what else can I do? I'm already very active. What should they be looking at, or what should they be doing differently? Because oftentimes you can't
A
tell a
tough
runner
one.
who's already running to run more.
Yeah, no, there's not a run more. I think, okay, so the big thing that we're missing is that a lot of these physiologic changes are actually normal. So if you're looking at somebody who happens to be that triathlete who's gained 10 pounds and feels like it's kind of around her belly, obviously making sure that there's nothing obvious within her diet or lifestyle that can make a difference. Her lab wise, if she's not diabetic, she doesn't need medication for anything. It's having a level of understanding that physiologically as we age, this is a normal process. We don't have to like it,
Yeah.
I would really reinforce I want you to keep doing what you're doing because you're not overdoing it, you're not underdoing it, and you're healthy. And, as much as 5 pounds, and for some women, it's literally like 3 to 5 pounds and they're distressed about it,
Yeah.
talking about it and reassuring them that this is a normal process at times can also help with some level of acceptance, especially when they're in the position where these physical changes have happened, but health wise, they're actually in a very good state of health and they're pretty optimized.
And do you ever talk to them, like especially people that are doing lots of cardio, but maybe their numbers are changing a little bit, and trying to talk to them about maybe backing off on the cardio and switching
Yes,
what they're doing, which is a
correct.
very difficult conversation for those people that are like, I get my dopamine high from running, and you
Yep.
are telling me to stop running, or telling me not to run 5 or 10 miles a day, but now changing some of that and doing something else.
Right. I used to see a lot of patients who were really hooked on the cardio, but I think that the trend of realizing that strength training is really, really important, especially as we get into our 40s to 50s. A lot of these patients are already starting to do that just because they're on TikTok, they're on social media, they're seeing, their fitness trainer friends and they already know about this. So absolutely. I think that conversation definitely tends to be a little bit more for the patients who aren't already doing all of the cardio. I'm finding that women nowadays I would say over the past 5 years are definitely combining that more often, if they've already been very active and they're making that progression from strict cardio to cardio and some resistance training. The other thing I talk to them about is balance and things
Yeah.
like yoga, things that can really help promote their, overall balance and stability as they get older, because that's something that a lot of us can face as we get older as well in terms of falls and that brings up things like osteoporosis and,
Mhm.
osteoporosis related fractures and, prevention of those. So
Yeah. And do you know any data specifically about like how much body fat, like when you hit a certain body fat, you are at increased risk, or, most women are just looking at the weight on the scale. But I don't know if there's any data looking at, if you are over a certain BMI, they definitely talk about it. But if you are over a certain body fat percentage, is there anything like that that women should be thinking about and worrying about as far as metabolic syndrome risks?
So when we look at criteria, we're looking at waist circumference. So waist circumference of greater than it's 35 inches for most women of Southeast Asian descent. I think it's 31.5 inches.
Hmm.
So more
Hmm.
of that central obesity picture as opposed to BMI. BMI greater than 30 is always thrown out there, but that's also obviously that,
Yeah.
obesity cutoff. So central obesity, it's more than the number on the scale. I mean, if somebody's getting on the scale, but they've been weight training, then obviously that
Yeah.
number means a lot less than somebody
Yes.
who hasn't been very active, isn't weight training, isn't exercising, and has that typical apple shape. So it's really much more waist circumference In terms of body fat percentage, I'll be honest, I don't know. I've always just
Okay.
focused more
Yeah.
on that waist circumference and that central obesity picture.
Yeah, no, and so have I. I just know that sometimes I have patients that come in as I probably more African Americans who may carry some weight in their belly, but maybe they carry it more in their butt, hips, thighs, and so
Right.
they don't typically have that as much of that abdominal or that apple shape, but they, may trend still having metabolic syndrome. And so for them, they're kind of like, they may or may not want to lose their butt, their hips, their thighs. And
I
so
would not
it's
lose my butt either.
so then it becomes that conversation because we are still talking about, yes, like what is that fine line? Because if you're still trending, elevated blood pressure numbers, or you're pre-diabetic, and talking about, okay, what are the things? Because sometimes they're just like, well, I don't have a lot of belly fat. That's not where, or
Right.
they're like, that's not where I carry my weight. It's kind of what they say. Like, I don't carry my weight
Yes.
there. I'm not that typical body shape. And so the conversation changes a little bit when I am talking to them. And I totally get it because I don't carry my weight there either. But, I don't know if you have had those patients who are then talking to you about, I'm not an apple shaper. I'm not as much of an apple shaper. Most of my weight is in another area that doesn't tend to go with what we usually think about with metabolic syndrome
Mhm.
and abdominal belly fat.
Well, I think it's also, it kind of goes along with the fact that when we think about using BMI, how, BMI was a way to kind of stratify risk. When we think about BMI of 25, once you're above 25 and you're in that overweight range, you have this increased risk of prediabetes, type 2 diabetes, all of the development of these things. But we also know that there are different ethnic parameters,
Yeah.
so depending on ethnicity, you can't use BMI of 25 as that, oh, there's that turning point in terms of elevated risk, or depending on the patient who's sitting in front of you. And I think that goes with just the fact that it's so important to individualize care and partner with the patient within the parameters of their perspective and their culture and their lifestyle and what's important to them. I mean, when we look at, if we're talking about, weight loss, we know that some as small as 5 to 10% weight loss can dramatically improve cardiovascular health and decrease the risk of type 2 diabetes. Well, a 5 to 10% loss may not put somebody in what we would think of as that normal BMI range, but that might be the place where they kind of settle, like that's where their body kind of sits. And
Yeah.
if that's where they always were in their 20s and 30s and 40s, and they got back to that place and their labs are normalized and they're feeling good, then we have to have some level of, it's not all about you must have a BMI of 22.
Yeah.
And I think that is also that important aspect, and understanding that people will have those differences in terms of what's important to them.
Yeah, definitely. Thank you for that. Let me check in the chat. I just want to make sure I haven't missed anything. And Britt, please let me know. I've been checking it. I haven't seen anything, but if you can see something I can't, please let me
Not
know.
yet.
I don't want to
No
miss anybody. Okay.
questions. So get
Okay.
those questions in the chat.
If there's anything that you all have questions about, if there are any questions that you would like to ask us, please post it in the chat and we would be more than willing to answer that for you. Is there anything else, Mary Beth, that we haven't talked about yet that you would want the other uh, physicians and providers on the call to know about, as far as when they are talking to their patients or looking at their patients, they are premenopausal, perimenopausal, or maybe even postmenopausal, and they are thinking these people may be at risk, and maybe there's something that they haven't addressed or information that is not often talked about?
Okay, so this is kind of a random off the chart thing, but obviously a lot of women have thyroid dysfunction. They have hypothyroidism, they're on levothyroxine or various other medications. Important to know that if you're a primary care and you're following a patient, for her hypothyroidism, and she is started by her gynecologist on hormone replacement therapy, important to follow up on thyroid function, because initiating menopausal hormone therapy can affect the thyroid levels and can lead to the potential of needing to adjust. So, I see a
Yeah.
question.
Oh, yeah. So first question, thank you very much. It says, history of unprovoked venothromboembolism on anticoagulation. Is that a relative or absolute contraindication to HRT?
Well, I personally, if somebody has an unprovoked VTE, meaning no prior surgery, no prior immobilization, et cetera, and I would definitely consider a workup. Is there an underlying thrombophilia, prothrombin gene mutation, factor V? If there isn't anything and they're on anticoagulation, I am not a big fan of starting menopausal hormone therapy because of that added risk of VTE. There's a lot of other factors, obviously. I mean, especially if it's somebody who had an unprovoked VTE, but she has a BMI of 40, we know that, women who have an elevated BMI are at a higher risk of VTE at baseline. So that in itself would tell me that adding something that is a thrombogenic agent like estrogen, would be an issue. Certainly not oral. There's the thought that transdermal obviously could be less likely to, provoke a VTE, but definitely not.
Yeah.
How about
And
you,
I
Shika?
totally agree
Starting
with you.
that patient?
No, I do not. I think I'm always thinking there's something else going on. Most of our patients are later in their 40s or in their 50s, and I'm thinking there's usually something else, even if it's unprovoked. And I really talk to them about the risks of
Yes.
being started on hormone replacement therapy, the fact that estrogen can, increase their risk, even if we are using patches and the risk is lower with patches, but it is not zero. And so, it's just having that conversation and really being able to help them to see why I would or would not do it. And then also talking to them about what are the symptoms that they're having? Why are they interested in starting on hormone replacement therapy? There are other options for them. So is it just hot flashes and night sweats? So I try to, find out, is it just vaginal dryness? Can I give them just, vaginal estrogen cream? And, how can I help them as much as possible? But really explaining to them why that's not my first choice and other things that can help them to still feel really good in their body without having that be the choice that we go through.
Absolutely. I see, Jennifer, you did not have to apologize, no worries. Talking about menopausal hormone therapy and decreasing weight. So we talked a little bit about the fact that obviously insulin resistance and that increased belly fat around the time of menopause transition obviously can really be an issue, and it's something that is really incredibly problematic and to a lot of patients. And I kind of compared that whole process of starting menopausal hormone therapy with respect to weight is almost similar to if somebody is out in the wilderness and they slice their arm open and they're bleeding and they put their hand on it. They're not going to fix that laceration that needs sutures, but they're going to stop the bleeding. So you can kind of help stop that escalation of the weight or that curve of the weight gain up, but it's not going to necessarily make the weight fall off unless their weight issue is related to things like really poor sleep, where they're eating more calories, that their brain is driving them to eat a little bit more, because of their lack of sleep, or they're having more anxiety as a result of menopause transition and their cortisol levels are higher, and that's driving things. So obviously menopausal hormone therapy can help alleviate some of those things, but I definitely would not put it into the category of a weight loss regimen. Most patients, when they come back for follow-up on menopausal hormone therapy, even if they are feeling great, we don't need to adjust their doses at all, their symptoms are resolved. Most of them at that 3-month mark, when I see them back to see how they're feeling, will actually still complain, everything else is better, but I still have this belly fat, So that's when I talk to them and remind them that just like any other way that you gain weight, in order to lose it, it's not just about taking something, you still have to put the effort in to lose it. So hopefully that helps a little bit.
Yeah. And that's exactly how I counsel the patients too. And I tell them sometimes the reason that they are not exercising, they'll be like, I feel awful. I'm always exhausted and tired. I am so mentally drained that I can't even think about walking, exercising, doing anything. And so when I'm talking to them, I tell them, hey, if we can get you better sleep, if I can have you waking up feeling well rested, everything doesn't seem as overwhelming. You actually have a little bit of mental capacity to deal with other things in life. Maybe you might be interested in going for a walk. Maybe you might be interested in, going to the gym or being a little bit more active at the end of the day. And like you said, you're not going to be up all night, maybe eating things that you shouldn't eat, or you aren't going to be, if they're a stress eater, whatever, all of these other little habits that a lot of times they've picked up. And now that also is contributing to that additional weight.
The other thing, Shika, that comes up is that, we always think about exercise, but we forget it about talking about non-exercise activity thermogenesis, or what we would call NEAT.
Mm-hmm.
What is that?
Yeah.
That's the general, I'm fidgeting in my chair, I'm standing up at my desk.
Yeah.
Going on menopausal hormone therapy and sleeping enough at night, oftentimes we'll move around a bit more during the day. We're less likely to just sit on the couch when we get home from work, even if we're just busy within our house or, running to the store. We just have a little bit more energy. And that can be the difference, between an extra 100 versus 500 calories in a day that end up getting burned just as a result of them feeling better.
Yeah, no, and I think that's definitely true. And actually talking to our patients about that, I think can be very helpful, because a lot of them are just thinking, oh, I have to go to the gym. Oh, I have to go for a walk. I have to do whatever. And just letting them know, even if you just move around a little bit more during the day while you're at work, can be so beneficial. You don't even realize it. But when you're exhausted and you're just kind of like, I can barely move, I'm like, it's a totally different thing than if you
100
are
to
able to get up and
500
down.
calories. If you're tired and you're not moving, you're burning an extra 100. You're feeling great and energetic because you had a good night's sleep, you're getting closer to that 500 without even going to the gym.
Yeah.
So it can
Yeah.
make a difference there.
And I think it's nice to emphasize that to them, because I think sometimes they feel so overwhelmed and they feel like the mountain is so high, especially when you're telling them, a person that has been formerly very healthy, never had any problems, and all of a sudden now, and a lot of them are like, I haven't done anything different. And for them, that's the thing. I'm eating the same. I'm, in their minds at least, doing all the same things I've always done. And now I have put on 15 or 20 pounds. And now my doctor's telling me I am pre-diabetic. And out of the blue, my lipid numbers are going up, and they're just like, but I didn't do anything and I don't know what to do differently, and I'm barely eating. And, for them,
And
they feels
yes,
like
I do
overwhelming.
feel like in terms of connecting with them, because I mean, this, almost every patient presents it that way. I'm not doing anything different. And what I found is the first thing that I need to do is validate them, because the likelihood is they aren't really doing very much different, at least that they can see. Maybe they're a little bit less active because that happens naturally with aging. That's just the way it is. But the fact is, most of them really aren't doing very much that's different. And that's why we see the trend that every single woman, for the most part, will end up gaining some visceral fat, abdominal fat during this time, regardless of how healthy they are.
Yeah. And I also tell them it's been something that has been changing for most people over a number of years. So no, it's not that you did anything really significantly different than yesterday or last month or last year.
Right.
But if you look back to what you did 10 years ago, you're like, it's been that slow progression or regression of whatever you were or weren't doing. And so that's why you don't notice it, because it came on really insidiously, and you've gotten so busy in life also, right? That the time that you used to spend doing other things has been really filled with other things. So you feel just as busy and just as active, but you're busy and active on a computer, not busy and active moving around. And that's what I try to tell them. Your brain feels like it's firing even faster now, but your actual body may not be moving as much.
Right. That's so true. So true. I think every single one of us deals with that. I mean, think about 15, 20 years ago, we weren't walking around with a phone. We weren't constantly having something in our hands that was preoccupying us and preventing us from moving.
Yeah. So let me see, make sure there's no other questions. And yeah, I don't see anything else. Just wanted to make sure. If there's any other questions, please let us know. We have like another 10 minutes, and Britt, right? 10 more minutes before we wrap this up. I just want to make sure I honor everybody's time.
Yeah, if there aren't any more questions, we can wrap up early, but we did schedule it for 60 minutes.
Okay. Sounds good. Well, we will give people just a couple of more minutes if you want to drop any last minute questions in the chat. We are still here, but we definitely want to honor your time. We really appreciate you all coming on. We know you all are busy and have so much going on, but we do appreciate you taking the time out to be able to better care for your patients as well as our community and ourselves. Anything else, Dr. Boardman, that I might have missed? Anything, other highlights, tidbits of information you want to share with us? Please take this time and go ahead and do that as well.
All right. I'm not thinking of anything right off the top of my head,
No,
although it's
no
always fun to
worries.
talk to you.
Well, okay,
No.
I'll chime in from afar
Yeah,
here.
please.
So, could you talk about the relationship to a dietitian? And listening to the conversation tonight and the importance, knowing what I know about dietitians and the services that they can provide, how do you counsel your patients on the role a dietitian might play in their healthcare plan?
Chiggy, you want to start or you want me to start?
You can go ahead and start. I mean, we have amazing dietitians, and so I partner with them all the time. Thank you for bringing that up, actually. You know what? They are so a part of my, like, I'm always referring to them, that I always forget to bring it up, and that other people may not be doing it or actively using them the way that we do at Gennev. So go ahead, talk about how you do it, and then I will tag along.
I absolutely love referring my patients, any of my patients who end up having issues with weight and concerns about weight, and especially the ones that say, I can't do anything different, because I can't do anything different sometimes can mean I don't want to do anything different, or I don't have the guidance to know how to do something that's different, because so many of us get so busy in our lives and get set in our ways. Having a registered dietitian and nutritionist who has an understanding of what's going on in the menopausal time period with insulin resistance, with this weight gain, means that you have somebody who can actually open the door to educating the patient on nutritional things that we may know a lot of, but they really have a level of expertise that's beyond what we can do within 20 or 30 minutes in talking with the patient. And it really just helps to support what I feel like they really help to support what I've already laid the foundation for with my patient. And then they just kind of take the the reins from there in terms of being really specific with the patients. And it's almost like getting down to the nitty gritty, tell me everything about what you're doing during the day. I look at these comprehensive notes that go through every single thing the patient has eaten for, a week straight, it seems. And then by the time I get to the end of the note, it's amazing how, very succinctly I'm getting information about, okay, this is what you're missing. You're missing this amount of fiber. We've talked about protein, and this is how much protein, and these are ways to get protein. And these are the, the foods that have high protein, especially for somebody who maybe has a dietary restriction, like they're vegan or they're vegetarian. I mean, as much as I thought I knew a lot about this stuff, I'm learning so much more and learning about it on a different level. And I have not had a single patient say that seeing the dietitian, the nutritionist, has been a waste of their time. Every single one is like, I wish I could do this for the rest of my life. Really incredibly helpful. And it's really nice. Again, it's another level of partnership. If we look at, okay, PCP who's managing, medical comorbidities, we're adding into that menopausal aspect of how menopause affects their medical comorbidities and how they're feeling about themselves and their menopausal symptoms. Now we have this third level. So it goes back to that, going through each layer. This is another layer, and it's a layer that, if you ask me, I think that it's completely underutilized in medicine. Introducing nutrition into the patient's world. We're all physicians, and I think a lot of us don't know as much as maybe we would want to or we should about nutrition. And then, we think about our patients, and we could already pick out some of the poor nutritional habits they may have. Oh my gosh, we're all in it together. It's just another layer of support that the patient gets. And they do it in a way that is, I'm going to see you next week. I'm going to see you the week after. We're going to see you, then we'll go to every 2 weeks. And having these tasks, my patients are relating to the nutritionists that they're seeing on a level that it's like, this is my really good old friend or big sister or person that I trust, who is really taking me through a difficult time and not making me feel bad about it. And they're learning the education that they're gaining from this is amazing. And it just reinforces everything that we're talking about with respect to, if they're on weight loss medications, they're on their, menopausal hormone therapy, and how they all play a role together.
Yeah. And I'll add, I've been able to refer to them, especially our patients now are so into social media and they get so much information off of TikTok and all of these things. And so when they come with these really advanced questions. And it's just not like, I want to do magnesium. They're like, what type of magnesium should I be on and how much? Right. And it's such a detailed question. And it's stuff that I'm like, it's next level. But I have found, like, when I refer to the registered dietitians, they can talk to them about magnesium and why they choose one magnesium over another. And even down to the fact when you are picking like a magnesium or any kind of supplement, how to know how pure it is, how good it is, what one is going to give you the biggest bang for your buck. I mean, they do an extreme deep dive. And like you said, no matter what dietary restrictions the patient has, they go through all of that. If the patient is interested in changing how they're moving, activity, they will really go through it all in great detail, especially if they have labs, they'll bring the labs in as well. So I find that it's very helpful because, again, it's not that level of knowledge that most physicians and most providers have, but they do. I mean, even I had a patient the other day asking me about creatinine and using creatinine supplements in addition to her magnesium and whey protein. And I was like, and the level that she was asking questions at some point, I'm like, let's get you a referral to the registered dietitian, because I know I've talked to them and they go into a deep dive and they can not only tell them the answer, but give them the studies and other areas and resources, which I think for those patients, they really appreciate. It's not just us trying to tell you something or sell you something. It's like, let me give you the data so that you can make the best informed decision. So.
Exactly.
There is a question. Can I refer patients to Genève nutritionists even if they are not receiving any other service from Genève? Yes, I believe they can, correct? Britt, they can refer directly to them?
Yes.
Yeah, they are amazing. So definitely you can refer straight to them. And if you want any additional information or having the physicians also look at them, they can do that as well. But we have quite a few patients who see just the nutritionist and we'll have everything done just with them.
You can refer them. It's just a nutrition and lifestyle referral. And also I would point out that our weight management program starts with the dietitian. That's the first intake appointment and then moves over to the doctor. So that's another pathway in a weight management referral.
Which is so helpful to have them start. I mean, again, because they are so comprehensive, in their intake, it's absolutely, it's just incredibly valuable when I get to see the weight management patients, myself. I feel like I can just go to that next level, based on seeing what their history is that they've taken and the level of detail that they provide.
Absolutely. Okay, well, thank you all. It is, we've got 2 minutes before the top of the hour. I really wanted to, again, thank you all for being here. Thank you for your questions. Thank you, Britt, for making sure that we brought in the registered dietitians. Totally forgot about them. I am using them all the time. So thank you for pushing that, because that's another great resource that we have available for both our providers and our patients. And thank you all for being here. We hope you all learned it a lot this evening, and continue to look out for our upcoming Menopause 201 webinars, as well as the ones that have happened in the past. They have been recorded and they are an excellent resource. And please share with any other providers and physicians that you know and invite them to join you on future webinars. We would really appreciate that.
It was so wonderful talking to all of you tonight. Thank you so much for listening and taking the time out of your schedules, especially at a time like now.
Yeah.
Appreciate it.
Thanks again. Thank you all. Have a good evening.
Bye-bye.